So let's talk about Toronto. We got a great new CEO of the Toronto Central Lynn, Susan Fitzpatrick. She and I have spent most of our lives together arguing with each other about what the situation, but we always basically agree in the end. But Susan's got a very neat idea about how this should roll out in Toronto. You know, she recognizes that there's huge thought leadership present in the hospitals, right? And that when you look at primary care, there are huge numbers of primary care providers. I was talking to Ruth Heisey, it's something like 140 primary care providers in Women's College. And, you know, total member, and Mount Sinai has family health team, UHN has family health team. So, you know, to think about the hospitals not leading this, but leading it kind of from behind. Sinai Women's College, UHN, leading from behind the organization and services in Central Toronto, as they have in the HealthLink development in Central Toronto. I think it's a great idea. And I know Susan's thinking about it, because, you know, the next question after you get primary care organized is, how does primary care get access to the services that are essentially in the hospitals? Diagnostic services, the specialist services. These services need to be integrated immediately with that foundational primary care platform that this system provides. And I know Susan and Joe, and this has been Marion's mantra forever, are thinking about how those services get integrated to that primary care platform.
One of the things you said in your response to Reza's question was that patients should have the freedom to choose, which is clearly going to be important to patients, and made me wonder what other things patients are telling you and what the process is for getting involvement and input from patients and the public in sort of answering the questions that are posed in the discussion paper.
Yeah. So, you know, patient engagement and getting patient feedback to this is crucial to the minister. We obviously have a web page where we're getting lots of responses. We're making a formal approach to provider groups. We've got a series of meetings scheduled with provider groups, and they're sending us their formal responses. But, you know, the LHINs are magnificent at community engagement, and the LHINs are doing public meetings, getting response and describing this. The other thing that we're anticipating at some point is having a more engaged process in the ministry. You know, the ministry, let's face it, we need to have a patient-family advisory process in the Ministry of Health. We need to have ADMs who are evaluated, you know, for the way they engage patients in their policy development. And Nancy's home care table, I can't remember how many patients are actually on your steering committee. Yeah. Yeah, so, you know, a substantial number, especially of care providers, advising as to how they want services organized for their loved ones. So we need to embed this in the culture of policy development in the ministry. I know it is in Ontario hospitals, becoming more and more a standard. So I think what we'll see is just a general culture of listening and engaging as being part of any policy development across our ministry.
Great. I know there was a question in the back there. Matt, you got it.
Hi, Dr. Bell. It's a privilege to ask you this question. So first of all, congratulations on the changes that was announced in December. I think there was kind of an elephant. I mean, you know, there's a phrase, there's an elephant in the room. There was an elephant in Ontario, and it's come, and it's a very exciting time, so thank you. Question is, I'm going to give you a scenario. So when you mentioned there's 2 to 3 months average wait times for long-term care, I would actually challenge that because there's quite a few regions that have been experiencing quite a lot more. And in terms of the projection of the capacity needs for supportive like housing or maybe not even long-term care, that's like needed. As you know, it's a tsunami, it's needed now. Some clients, unlike the one that you mentioned around being happy at home because they can smoke their cigarette and so on, is really...
I wasn't suggesting that it's a good thing.
It's not truly representative of the really a greater amount of the population. Having worked in community mental health and addictions at Canadian Mental Health Association as an executive leader just 2 years ago, we've struggled in our region trying to support these folks that actually need the home-like environments. So let's say, I'm really excited about the pilot idea. Let's say the 13 health and addictions agencies in a particular LHIN decides to do a pilot to increase the support outside of the hospital and long-term care homes. in terms of accountability. Can you define the accountability in terms of budget, the movement that will have to happen, because resources are not going to be necessarily increased. We've noticed that hasn't really succeeded, and that was done for the CCAC to what you want. So can you kind of elaborate in terms of accountability? If I was, let's say, in the LIN board, the new board, and I decide to move some of those dollars based on all the measures, is that something that the LIN would be given, accountability to be able to do, and as soon as possible, considering QI methodologies? Thank you.
Thank you. So I think probably the fundamental aspect of what you're asking me relates to, will dollars be fungible for LINs? Will they be able to transfer dollars around in the home and community? And the answer is yes. They'll be able to think through where the needs are greatest. So, the next question that gets asked, that I get asked regularly is, will they be able to take dollars away from hospitals and put them into better community mental health services? And, the ministry is going to remain tightly tied to hospital funding. Right now, we provide the LINs with hospital funding, but based on a variety of different formulations, we tell them the Mount Sinai Health System is going to get this amount of funding. And for the time being, that's going to remain the norm. Why do we say that? Well, hospitals have done a remarkable job in this province of becoming more cost-effective as well as higher quality. I just saw some data demonstrating that the average cost per weighted case in the province, not in inflation-adjusted dollars, but in real, in dollars, has actually gone down the last 3 years. And the kinds of programs that we got in place around health system funding reform and quality-based procedures, we want to continue. In order to continue that, we need a standardized approach across the province so we can compare hospitals in various regions that are risk-adjusted for rurality, risk-adjusted for the age and growth in the community. But we want to keep that tie, at least for the next few years. I think it's fair to say, Nancy, in order to maintain that progress that we've demonstrated in hospitals, so that hospital dollars won't be fungible, but certainly dollars within home and community care. The other thing to say is that we're reaching a good point for funding of home and community services, in that the first few years of the 5% increase that we put into home and community annually has really gone into solving the precarious work issue present in home and community. Personal support workers, who are really the major providers in home and community care, have really had precarious work. And we've stabilized that precarious work with a minimum wage of $16.50 and wage moving up toward $19. So that's become far more standard. The conditions of work far more standard. And now I think the funding increase can actually be put into not only reorganizing care, which we think is huge opportunity for improving care, but also into expanding the amount of money that actually goes into home and community care. So we're pretty excited about that.
Thanks, Dr. Bob Bell and Irfan Dhalla. So I had a question regarding innovation in the healthcare system. The recent NAILA report highlighted a few opportunities for change and to spread and scale innovation in our healthcare system. You had mentioned in your speech a little bit earlier that primary care will be linked to the LINs. Can you comment on opportunities to spread and scale innovation in our healthcare system in this connection between primary care and the LINs? We know that 70% of all healthcare encounters occur in the primary care setting. So if you can think of opportunities to spread and scale innovation for patient and family engagement in that context.
Yeah, thank you. So the most innovative place right now in Ontario in primary care, to me, is Chatham, Ontario, where they're actually defining performance in primary care by looking at the appropriate use of acute care services by a population, which is very, very cool. So all primary care providers are connected to the local hospital system. And, if their patient is using those services in a way that differs from how they've traditionally used it, suddenly resources are available for stabilizing those patients in community. And it's very interesting because, you know, we've looked for all kinds of triggers as to what defines a complex patient. How do you know when a complex patient is becoming complex? They defined in Chatham-Kent, based on a pretty straightforward IT investment, is, well, if a patient goes to the emergency department 3 times and 3 times over a period of time, chances are that patient's becoming complex. And it's time for that patient to have access to a care coordinator, it's access to a variety of resources in the community that are sort of health links resources. So, you know, that innovation is occurring. There's fabulous innovation in Collingwood, where all primary care IT systems are actually hosted. Collingwood Hospital, he's here today, and that's led to a wonderful sense of interaction between the hospital and primary care providers, and kind of a service mentality in primary care, and kind of a social obligation of primary care to be engaged in the hospital as well as in planning services. So there's lots of innovation across the province, and I think having this Sublin regional approach and, you know, I mean, documenting and demonstrating what's going on in Collingwood, what's going on in Chatham, gives us an opportunity to look at innovation scaling way more rapidly than it has previously.
You know, a reasonable proportion of these innovations are physician-led. And, you know, I think it's probably everybody would agree that all of the reforms that are being proposed are likely to succeed faster and better if physicians are behind them. So, since no one in the audience has asked the question, let me. What is the sort of thinking around the game plan to get physicians back to the table and to resolve the dispute?
Yeah, so, you know, the 2 things that represent a bit of dissonance in terms of this plan are, first of all, the fact that there's been so much finger pointing in home care, and secondly, the fact that there's no physician services agreement. And, you know, we absolutely continue to talk to the OMA on a regular basis, recognize that the representation rights process, we wouldn't talk to anybody but the OMA about compensation for physicians. But, you know, physicians are also interested in their work life. And their work life depends on whether or not they get access to their patients for home care, whether or not they get access to their patients for the variety of services that we're talking about, whether or not they have to send their patient to the emergency department of Toronto Western Hospital, get a CT scan for a headache, or whether they can actually call Toronto Western Hospital and get a neurologist to assess or an internist to assess the patient, you know, in a timely fashion. So clinicians, I find, are very interested in their work life, very interested in the ease with which they can achieve resources for their patients. And this is not about how much we pay doctors. I wouldn't come close to that discussion in this room. We want doctors to be well paid. We want doctors to be happy. We want to talk to the OMA. We want to have an agreement with the OMA. But in the absence of that agreement, we'll continue to talk to clinicians and thought leaders like yourself, like David Price, others around how we can improve the work life of physicians, which inevitably improves the care they can provide to patients. And we haven't had difficulty in engaging those conversations to date.
We are at 8:59, and I know when these sessions are done at hospitals, people generally have meetings at 9, so I just want to say a few thank yous. First, thanks to you, Bob, for your candor and the thoughtfulness. And thanks also to your colleagues in the ministry, and you mentioned Nancy and a few others by name, but I know this reflects the work of a lot of folks, so thank you. I also want to thank Marion and Joe for hosting us here at the Sinai Health System. And lastly, and most importantly, thanks to Anton and Matt and the entire Longwoods team for this great opportunity.
Terrific.
Thanks.